Alright, so we're going to talk about some of the bugs that infect the skin. This isn't going to be a total dermatology review, of course. This is just the infections that happen in the skin. Alright, so we're going to talk about 9 different infections of the skin. And what is this? So let's say this is a 12-year-old boy, 10-year-old boy. Mom brings him in, worried about this. Worried that he's getting acne. What do you say? You say that this is impetigo. So impetigo is characterized by a superficial ulcerative pustular lesion. Sometimes there's multiple of them, and they most commonly occur on the face, but they can occur on the extremities and the rest of the body as well. The pus from the lesions is going to drain, and a lot of times it hardens, and that creates the stereotypical honey-crusted lesion. So you can see here that there's some yellow encrustment. So this is the honey-crusted lesion. And you see that a lot. It's a buzzword that you see come up a lot on the USMLE. It's more common in pediatric patients. Not that it doesn't happen in adults, but adults tend to see this and they think, oh, it's just acne. And they don't come in. So the offending organisms, historically, it used to be group A strep related, so strep pyogenes used to be implicated the most, but nowadays Staphylococcus aureus is the most common cause of impetigo. The diagnosis is made clinically. Rarely is the patient going to have any other symptoms besides just this little skin rash. The treatment is going to depend on severity. The vast majority of cases of impetigo are not severe. And so we usually just treat this topically with an anti-staphylococcal antibiotic. And we'll use mupirocin or bacitracin. The more severe cases, or if they're not responsive to the topical therapies, we can use an oral anti-staphylococcal, which would include oxacillin or nafcillin. Now there are sequelae that can exist from impetigo, but provided that we treat the impetigo, it's pretty rare. So the primary sequelae that comes out of impetigo would be glomerulonephritis, and that's if it's caused by strep pyogenes. But this is rare enough to the point where it's not significant for the USMLE as far as impetigo is concerned. So here's another patient with impetigo, again, honey-crusted lesions. Alright, what's this? So clearly here you've got erythema, but here you've got healthy tissue. So this is Erysipelas. Erysipelas is an infection of the superficial layer of the epidermis, and it's differentiated from cellulitis in that it's got clear demarcated boundaries. You could draw a line right here between the border of the healthy appearing skin to the very not healthy erythematous appearing skin, and also right here. So this is technically Erysipelas. And that's the only way it's differentiated from cellulitis. There are risk factors for developing erysipelas, and that's pre-existing lymphedema or recent trauma, which would introduce bacteria into the skin. The offending organism tends to be strep pyogenes, and the symptoms would be shiny red indurated skin, which we would define as a plaque, with well demarcated boundaries. It's basically cellulitis with demarcated boundaries. The diagnosis is made clinically. However, what's important to keep in mind as far as treatment is that erysipelas tends to coexist with cellulitis. And cellulitis is more severe, and it's going to be a different treatment. So when we have erysipelas on a patient, we usually are going to treat them for cellulitis, just because we don't want to miss one by being too careful. So penicillin technically would be sufficient for erysipelas alone. However, we're usually going to treat for cellulitis. And here's another picture of, this is just textbook erysipelas. Now here would be cellulitis. You don't really have a boundary here. It's not demarcated. Here, very demarcated. Here, not so much. There's just sort of this generalized erythema. Ignore what this is up here. But there's just this generalized erythema in her right foot, or his right foot. So cellulitis is an infection of the epidermis. It's a little deeper than erysipelas, and there's no clear demarcation, and it is more severe than erysipelas. So the risk factors for cellulitis is diabetes mellitus, which reduces your immune system, an immunocompromised state, HIV and AIDS if it's progressed, cancer, venous stasis, immobility, paralysis. All of these would reduce your movement or reduce your immune system. So in any patient who has cellulitis that's immunocompromised, you should assume that they have a community-acquired strand of MRSA rather than just simply Staph aureus or Strep pyogenes. The symptoms for cellulitis are going to be local pain, surrounding erythema, warmth, local lymphadenopathy, and constitutional symptoms can be present if the cellulitis has progressed enough. The treatment is going to be with anti-staphylococcal drugs, and we're going to give those PO. So oxacillin or nafcillin would be preferable drugs. In patients where we're assuming MRSA as a possibility, which would be immunocompromised patients, I would even go so far as to say even diabetic patients, we should use vancomycin or linezolid to cover MRSA. And here's some more pictures of cellulitis, again, not very well demarcated. Okay, what's this guy have? So this is something totally different. This guy's got ringworm. So ringworm, otherwise known as a dermatophyte infection, is a fungal infection of superficial skin, which of course is dead tissue, and this results in white plaques with annular erythema. So white plaques would be the fungus itself if it's there. Sometimes you don't see it. But the annular erythema you will see, and that's the redness around, it's sort of a circular redness or a semicircular redness. And so you see it here, you see the white plaques which are surrounded by a redness in his skin. The symptoms the patient may complain of are itching, they've got a plaque, it might burn, and it might have a bad odor depending on where it's at. This is diagnosed clinically often, but on the USMLE, the best first step is a potassium hydroxide exam, and all you're doing is you're taking a little bit of the plaque, you're scraping it into a, I don't know, you use a vial or a slide, and then you take that slide, you put a drop of potassium hydroxide on it, and that's going to separate the fungus, and you should be able to see the hyphae quite well, and that will give you a positive diagnosis. However, so that's your best first step in diagnosis, but the most accurate test, of course, like in any microbiology, is fungal culture. Culture is best, is always the most accurate, but it's not always the best first step. Sometimes you may see that the USMLE might tell you Woods lamp positive, or maybe even on the wards you've used a Woods lamp before. All that is I think it's like a UV light, and it would demonstrate UV reflectance if there is a fungal infection positive. The treatment's going to depend on the location. For the body, head, and for the nail, you're going to use a PO antifungals, terbinafine or itraconazole would be fine. The reason you have to use it in the nails is because you can't get any kind of azole ointment into the nails. The body and the head, I'm not exactly sure why you need to use PO therapy, but you should know body, head, and nail, you do need to use PO therapy with terbinafine or itraconazole. With Tinea pedis, which is athlete's foot, Tinea cruris, or Tinea barbae, which is where it occurs on the face, you can use a simple azole ointment, and those ointments include miconazole and clotrimazole and so forth. So body, head, and nail, you're getting terb and itra. Foot, groin, and face, you can use ointment. So here's some more examples. This is Tinea capitis, like in the other patient. This is a little less severe. Here's Tinea cruris. Again, you see that annular erythema where you've got most of your redness around the periphery of the infection. Tinea unguium, or tinea of the nail, is very obvious. You've got this white plaque underneath the nails. This is very prevalent. Tinea pedis, or athlete's foot, this is obviously a very severe case, but again, you've got some significant erythema around white plaque. Okay, so we talked about dermatophyte infections, which are infections due to specific fungi, which are Microsporum, Trichophyton, and Epidermophyton. Now, Candidal infection is a fungal infection as well. It's a fungal infection of dead tissue of superficial skin. It results in white plaques, and there's sometimes some annular erythema around it, but more so what you'll see in a Candidal infection, which is due to Candida, is surrounding peripheral papules or lesions. So flaking and peeling can occur here. It's worse with immunocompromised patients, with pregnant patients, with immobile, obese, patients with blood dysprasia, HIV, steroids, diabetes mellitus, anything that's going to mess up your immune system. So there's some similarities to the dermatophytes here, but when you look at the pictures, you're going to see the difference. So the symptoms are also similar: itchy, burning, inflamed plaques with sort of a circumferential edema or erythema. And really the other symptoms are going to depend on the location. So some of the locations that you can get Candidal infections in really are any of the locations that are dark, moist, and warm for long periods of time. Now think about it. When you get yeast on your bread, you get it when you have moist bread and you stick it in the refrigerator or in the cupboard, which is a nice cool area, and it's dark. It's perfect for fungus. Well, these places are perfect for fungus too. So intertrigonous candidiasis is, again, like we said, erythematous skin with white plaques and the satellite lesions. And these are seen under, what makes it intertrigonous is that they're seen under skin folds, like the groin, the umbilicus, the axilla, or underneath the breasts. And you'll see this more in the obese because they've got more, to put it in an immature way, fat rolls that they can get moisture and darkness and heat, and that can grow this kind of fungus. Of course, vulvovaginitis, a yeast infection, another place that's moist, wet, dark, perfect place for yeast. And the symptoms would be vaginal pruritus and discomfort, and this will be noted on speculum examination. You'll see a white curdy discharge. Oral or esophageal thrush, the symptoms would be odynophagia. Of course, if it's just oral thrush, you'll be able to see it on physical exam. To diagnose this, it can be diagnosed clinically. However, for the USMLE, a potassium hydroxide exam would be the best first step, and a fungal culture would be the most accurate. So topical therapy is generally appropriate for any kind of Candidal infection. Nystatin or clotrimazole are used. Nystatin would be used for the esophageal thrush. You'd have an oral swish and swallow. Or if it's just oral thrush, you'd just have an oral swish and spit. Vulvovaginitis, you would use clotrimazole. Intertrigonous candidiasis, you would use a topical nystatin or clotrimazole. For severe cases or any patient who's immunocompromised, you can use systemic therapy, in which case you'd use amphotericin B. Okay, so I want to point out the difference between dermatophyte infection and candidiasis. So if you look here on candidiasis, you have redness throughout the entire lesion. Okay, so you might be able to pick up plaques. You probably will be able to pick up plaques in this lesion, but there's severe erythema. It looks much more painful. But what you have that really sets this apart are these satellite lesions, these papules. They look like little pimples, and they occur along the periphery of the infection. So you got one here, you got one here, You can go over here, you got one here, got one here, got one here. Now, on the other hand, you don't see that with Tinea cruris, with the jock itch, which is a dermatophyte infection. You do have the annular erythema. You have a ring of redness, but you don't see the satellite lesions. You don't see those pimples. Plus, on the inside of the infection, as you get more medially, it appears much more healthy. You don't have nearly as much erythema. So the dermatophyte infections are more of like a ring, whereas the candidiasis infections are erythema with a ring of satellite lesions. And then here's some more. These are also Candidal infections. So again, you see satellite lesions. This is a baby with a yeast infection, but this is due to diaper rash. So diaper is another dark, wet, moist place for fungus to grow. This is oral thrush on the tongue here, and here's some oral thrush on the soft palate. Here's some more yeast infections. This is an axillary yeast infection. This is vulvovaginitis. Looking with the speculum, you can see here that you've got no abnormal drainage from the cervix, but you do see on the vagina, you do see that curdy discharge that's associated with vaginal candidiasis. Okay, and then here, this is another common thing you'll see. Again, lots of satellite lesions here, lots of these little pimple-looking things, and then just redness. And this is underneath the breasts. This is very common. Okay, what's this? So this is a guy that normally he's a pasty-faced white guy. Let's say he's of Swedish descent, and he went out for a suntan and got nice and tan all over his body, but somehow his back is looking like this. And this man has Tinea versicolor. So Tinea versicolor is also a fungal infection of the skin, and it's characterized by plaques of low pigmentation. And it's most noticeable if a patient tans or if they're of dark complexion, and the lesions tend to coalesce over time. So this guy probably had this fungal infection on his back for a while, but then when he went out to tan, his unaffected skin tanned, and the tinea skin did not tan. And the result of that was this noticeable pattern. And so the patient will usually notice the plaques before other symptoms develop. Now what you would want to do here, because on your differential diagnosis, you may be thinking other things. What you want to do here first, anytime you have a patient that comes in like this, is that you're going to want to try to scrape anything you can off of these lighter pigmented areas. And the reason is because you're trying to differentiate this from vitiligo. Vitiligo would be less common, but it's a possibility to show a pattern like this. And vitiligo is an autoimmune disorder. So you want to try to get some scrapings off this patient, and then you're going to do your potassium hydroxide exam. That's the best first step. And indeed, if the test is positive, it will reveal what the pathologists always refer it to, and what the USMLE will tell you as, is spaghetti and meatballs morphology. Don't ask. The treatment for Tinea versicolor is topical selenium sulfate, and that's generally enough for patients. The organism here is Malassezia furfur, and that's the only time you're ever going to see this organism, is in Tinea versicolor. Here's some more pictures of patients with Tinea versicolor. Okay, how about this guy? So he's got some excoriations here. Looks like some ulcerations. I don't know if those are veins or what those things are underneath his skin. What is this? What's that? This is scabies. So scabies is a parasitic infection. The parasite burrows in and out of the skin and then back in again. and it leaves behind a trail of inflammation, mast cell response, as well as a susceptibility to secondary infection. The organism here is Sarcoptes scabies, and the symptoms are going to be chronic, severe, intense pruritus. Why? Because you have an inflammatory response. You have mast cells releasing histamine. That's going to cause severe itching. And it's going to be chronic because this isn't something that's going to respond to an antihistamine. It's not going to respond to anything but the treatment that's used to get rid of scabies. So if this goes undiagnosed, it's going to progress and progress and progress, and it's just going to get worse and worse. Now, this usually tends to be localized to one region, but it doesn't have to be. And the areas it tends to occur most often on is the flexor surfaces, the finger webs. It can also occur on the areola of the female breast and on the genital area on the head of the male penis. So what you'll see in scabies, if you're suspecting it, you will see one if you look hard enough. If you're suspecting it and you look hard enough, is you'll see short, elevated, pink-gray, straight to tortuous lines. And what those are is actually the scabie itself burrowed inside of the skin. And so that's what this is right here. This is a scabie inside of the skin. It looks kind of like a vein. It's not a vein. This is a line, and this is the scabie organism. And this red here is the scabie that's getting ready to burrow out. So for diagnosis, it's direct visualization in mineral oil, and you read the medical textbooks and it tells you all about how to try to manipulate the scabie out. That just sounds disgusting, in my opinion. You know, if you want to do that, go ahead. However, what you should know is that a negative test doesn't rule out scabies. So if a patient has a pattern of scabies and a history of scabies and contact with patients with scabies, then you're probably going to be treating them for scabies, especially since we're only going to be treating them with a topical ointment. So there's really not much toxicity in that. Permethrin is the topical treatment of choice in most patients. If that's ineffective, we can use lindane in addition to permethrin, but we never use lindane in patients who are pregnant. Now, if the patient has a severe scabies infection and you have directly visualized the scabies in mineral oil, and or if the patient is immunocompromised, then they should be treated with a combination of permethrin and ivermectin. And here's some more patients with scabies. Here's that line with the burrow right here. And here's some in the webs of the fingers. You see something like this in the webs of the fingers, definitely be thinking scabies. Not a lot of things happen in the webs of the fingers. Okay, I didn't have a picture of this, or at least one that would be clinically useful. So pediculosis, or otherwise known as lice, is also a parasitic infection. This is also very common in children, and it can occur on the head, on the body, or in the pubic region. And the offender that occurs in the pubic area, the pubic offender, pardon the pun, is Erysipelas pubis, which is the crab louse. Symptoms here are going to be intense pruritus localized to one area. And you will easily be able to find these on exam in the hair. In the pubic hair, in the head hair, wherever the hair is that people say is itchy. So you should be able to find these, unlike the scabies, since they're not underneath the skin, they're on the hair. It should be relatively easy to find these. The diagnosis, therefore, is by direct examination. That's our first diagnostic step of choice, and it's the most accurate test, as far as I know. And the treatment here is also going to be permethrin, because this is another parasite, and we can kill the lice in the same way that we kill the scabies. So permethrin. Okay, last one. What is this? Mom brings her kid in because he's getting these weird bumps all over his body. This is called Molluscum Contagiosum. I guarantee you will see this on a question on the USMLE Step 2 and Step 3. Molluscum Contagiosum is caused by the pox virus. It's extremely common. It's a viral skin exanthem, and it occurs in children and young adults and in immunocompromised patients, but it can also occur in older adults too. This is spread by skin-to-skin contact. The symptoms are pruritus if there are symptoms at all. A lot of times this will just be found coincidentally by the patient or by the mother or by the physician. These are approximately 1 to 3 millimeters in diameter. They're non-pigmented, and they have a characteristic central umbilication, which when you see that central umbilication, it's a dead giveaway that it's Molluscum Contagiosum. And usually there's going to be more than one. The diagnosis is entirely clinical. We are not going to biopsy this. We're not worried about anything else. We know what this is just based on the fact that there's a central umbilication. We can take these off if there's a ton of them, if they're on the face, if there's some place where the patient doesn't want them and they really want them gone. We can remove them through freezing or curettage, probably done by a plastic surgeon, because most of the time when people want these removed, they're on the face. But if they need to be removed on the arm or on the leg, a general practitioner can do that in the office. But the good news is these are generally self-limited and they'll go away on their own. And here's a couple more pictures. You can see how these might get confused with chickenpox because they look like papules in various stages of healing and formation. Here's some new ones. Here's a big one with an umbilication. Here's one that looks like it got picked off. But Molluscum Contagiosum always is going to have that central umbilication. And you can see the central umbilication in all of these. So this is quite clearly different from chickenpox, even though you do have that multiple stages of healing that is so commonly associated with chickenpox. And of course, they're both have the word pox in them, so that's probably why people get them confused too. But just look for the central umbilication. That means Molluscum Contagiosum. And that's the end.